If you feel like the world of medicine has been kind of stuck in neutral, just little tweaks here and there, then get ready, because 2025 is shaping up to be a seismic shift.
It really is.
We are moving way beyond those small gains and into, well, entirely new ways of thinking about therapy. We've pulled together senior medical editor reports, conference notes, key papers that are rewriting the textbooks as we speak.
And that's the consensus across all of them. The front lines of pharmacology are actively solving some of our most stubborn, long-standing crises.
So for our deep dive today, we're focusing on 3 of those.
Exactly. 3 distinct, really high-impact breakthroughs. We're talking about a targeted therapy for notoriously aggressive cancer, a non-addictive answer to the opioid crisis, and finally a drug that is completely redefining how we treat chronic kidney disease.
And that's our mission here. To cut through all the jargon and pull out the most critical, needle-moving insights for you, we need to know not just what the drug is, but why it matters. What are the real-world trade-offs? Okay, let's unpack this. And we're going to start with a cancer that has been, for decades, just a complete medical nightmare.
We begin with small cell lung cancer, SCLC.
Exactly. SCLC is just the monster in the room for oncologists. It's known for 2 horrible things. It grows incredibly fast, and it spreads early. For decades, once the standard chemo stopped working, the options were, well, there were no options.
The prognosis was just grim. But that era of helplessness is, it's finally starting to crack. Our sources are all highlighting what they're calling the biggest advance in 40 years for these patients.
And that is?
A drug called tarlatamab. You'll see it marketed as Imdeltra. As of November 2025, the FDA granted it traditional approval for patients with extensive stage SCLC after their initial chemo has failed.
So this isn't just another line of defense. This is a whole new playbook.
It really is. It validates a completely new approach.
Okay, this is where we need to get into the weeds with the data, because the numbers really tell the story. The main trial, Delphi 304, had about 500 patients, right?
509, yeah. And what they saw with survival was just monumental for such a fast-moving disease.
So what was the number?
The median overall survival, which is the gold standard, how long patients live, it hit 13.6 months in the tarlatamab group.
13.6 months. And what was it for the standard chemotherapy group?
Just 8.3 months.
Wait, hold on. 13.6 versus 8.3. That's more than 5 extra months of life. In a disease like this, that is an eternity. That's not a statistic. That's real time with family.
It translates into a huge practical impact. And if you look at the main risk metric, the hazard ratio, it was 0.60.
Which means?
It means a solid, statistically significant 40% reduction in the risk of death compared to standard care. And on top of that, 40% of patients saw their tumors actually shrink.
Okay, now here's where it gets really interesting for me. Tarlatamab isn't chemo, and it's not the kind of immunotherapy we're used to hearing about, like a PD-1 inhibitor. So what exactly is it?
It's a newer class of drug called a bispecific T-cell engager.
A BiTE. I saw one of our sources call it micro handcuffs, which I think is a great visual.
It's perfect, actually. The tarlatamab molecule has 2 ends, like 2 little hands. One hand is designed to grab onto an antigen called DLL3.
And that's only on the cancer cells?
Almost exclusively on small cell lung cancer cells, yes. And the other hand grabs onto the CD3 antigen, which is basically the on switch on your body's own T cells, the immune system's killer cells.
So the drug is literally a bridge. It physically connects the T cell and the cancer cell.
It forcibly drags the T cell right up to the tumor. It bypasses all the clever ways the cancer tries to hide from the immune system. And once they're locked together, the T cell gets activated for what you could call close quarters combat.
And then what happens?
It releases these toxic proteins, perforin and granzymes, that basically punch holes in the cancer cell and cause it to explode.
That is incredibly powerful, but if you're forcing that kind of intense immune activation, there have to be safety concerns, right? I mean, a 40% reduction in death risk is amazing, but is the trade-off worth it?
That's the critical question. And yes, because the immune system is activated so aggressively, the FDA did issue a boxed warning.
A boxed warning for what?
For cytokine release syndrome, or CRS, which is essentially that systemic immune storm you mentioned, and also for neurologic toxicity. So while it's powerful, it absolutely requires careful handling.
So how do doctors get around that? How do they manage the risk?
They use a safety protocol called step-up dosing. They start with a tiny dose, just 1 milligram on day 1. Then they escalate to the full 10 milligram dose later.
Ah, so you let the body get used to it first.
Exactly. It helps mitigate that risk of an overwhelming immediate immune response. It's a targeted weapon, but one that demands a lot of vigilance.
Absolutely. Okay, moving from the fight against cancer to Another huge societal crisis, pain management.
The opioid crisis.
For years, we've been stuck, right? It's either stuff that doesn't work for real pain, like ibuprofen,
Yeah.
or you have the fatal risks of addiction and respiratory depression from opioids like fentanyl or Oxycontin.
And it's that dilemma that has fueled this whole crisis, which is why this new drug, suzetrigine or VX-548, is being called a potential holy grail.
A holy grail. That's a big claim.
Well, it promises strong pain relief without that devastating addictive potential.
How does it do that? How do you get the power without the risk?
The mechanism is just. It's incredibly elegant. Suzetrigine is a highly selective inhibitor of a target called NaV1.8.
Okay, NaV 1.8. Break that down for us.
It's a sodium channel. Think of it as a tiny molecular gate that lets the electrical signal for pain travel along a nerve.
And the crucial part is where this specific gate is found, isn't it?
This is the Nobel-level insight right here. The NaV1.8 channel exists almost exclusively on our peripheral pain neurons, the nerves out in your tissues that sense an injury.
Not in the brain.
Critically, not in the central nervous system.
Mm.
So it isn't in the brain, and it's not in the parts of the body that control your breathing or your heart rhythm.
So you're cutting the wire at the source of the pain instead of trying to mess with the control panel in the brain.
Precisely. It blocks that NaV1.8 gate in the periphery, so the pain signal just stops. And because it doesn't get into the brain, it can't cause euphoria. That's the feeling that drives addiction. And it doesn't slow down your breathing.
I mean, that's just a massive relief. To know you can manage serious post-op pain without that constant fear of addiction. The data from the big Phase 3 trials must back this up.
They absolutely do. They looked at over 2,000 patients after procedures like abdominoplasty and bunionectomy. The primary metric, SPID-48, showed a clear, statistically significant improvement over placebo.
And the safety profile, that's the big one.
Almost too good to be true. The rate of adverse events was actually lower than in the placebo group.
Lower than placebo.
50% versus about 56%.
Yeah.
And most importantly, no addictive potential and no signs of serious respiratory depression. None.
I saw the American Society of Anesthesiologists is calling it the biggest advance since opioids themselves. But let's talk about the limitation. How does it stack up head-to-head against a strong opioid?
And that's the key nuance. In a direct comparison, suzetrigine did not show a statistically significant stronger effect than, say, a hydrocodone combination pill.
So for the absolute most extreme, catastrophic pain major trauma, that kind of thing, opioids might still be on the table.
That extreme end of the spectrum, yes. But suzetrigine is more than strong enough to replace the vast majority of opioid prescriptions written for moderate to severe post-surgical pain. And that's where the crisis begins, with those first prescriptions. This could change everything.
Let's transition to our third breakthrough. And this one requires us to completely reframe how we think about one of today's most talked about drugs, semaglutide.
Right, the GLP-1 agonists.
If you only know these as weight loss miracle drugs, you are seriously underestimating their future role. The results from a study called the FEFALO study are completely changing kidney medicine.
This might be the biggest paradigm shift of the year. The FLOW study was the first large-scale trial designed specifically to see if a GLP-1 drug could protect the kidneys in patients who already had type 2 diabetes and chronic kidney disease.
And this was a big trial.
Huge! Over 3,500 patients followed for more than 3 years. And the fascinating thing is, the study was stopped early.
Why?
Because the efficacy was too good. When a trial for a progressive disease gets halted because the treatment is working too well, you know you have something transformative on your hands.
So let's look at those numbers. The primary outcome was a composite of really bad events. Kidney failure, a huge drop in kidney function, or death from kidney or cardiovascular causes.
And the risk of one of those major kidney events happening was cut by an incredible 24% in the semaglutide group.
24%.
But it's not just that. The risk of dying from any cause, all-cause mortality, was reduced by 20%.
So this is doing way more than just managing blood sugar. It's actively protecting the organ itself. I saw the data on the rate of decline in kidney function, the eGFR slope.
Yes, that decline was significantly slower, about 1.16 milliliters per minute less per year. It means the drug isn't just treating symptoms, it's actually interrupting the disease process that leads to organ failure.
Okay, so help me understand the mechanism here. How is semaglutide acting as a kidney shield?
This is that multidimensional or pleiotropic effect of GLP-1s. The receptors for this drug aren't just in the pancreas, they are found directly in the kidneys and blood vessels. And it seems to work in two main ways.
What's the first one?
First, hemodynamics. In diabetic kidney disease, the little filters in the kidney, the glomeruli, are under really high pressure. It's a state called hyperfiltration. Semaglutide reduces that pressure, kind of decompressing the filter and easing the strain.
So it lets the kidney relax a bit.
Exactly. But the second mechanism is the real game changer, and that's its anti-inflammatory and anti-fibrotic action.
Meaning it stops scarring.
Precisely. Chronic inflammation causes the kidney tissue to scar over time. That's fibrosis. And that scarring is what ultimately leads to kidney failure. Semaglutide seems to directly inhibit the inflammatory signals that cause this scarring.
Which traditional diabetes drugs just can't do.
They can't. They can lower blood sugar, but they don't stop the scarring. This drug interrupts the pathological train that's heading toward complete kidney failure.
So connecting this to the bigger picture, where does this put semaglutide in the treatment guidelines now?
The International Society of Nephrology moved fast. They're calling GLP-1s the third pillar in protecting the diabetic kidney, right alongside two other classes of drugs, RAS and SGLT2 inhibitors. They're saying we're in the era of the three kingdoms now.
But there are still challenges, right? What were the limitations here?
Well, cost is a huge one globally, and the side effects are real. GI issues like nausea and vomiting are still the main reasons people stop taking it. And importantly, the FLOW study was only in type 2 diabetes patients. We think it should work in other forms of kidney disease, but we don't have that data yet.
Okay, so let's just step back and synthesize all this. We've seen three completely different therapeutic logics today. We have BITE technology using the immune system to kill cancer. We have selective sodium channel blockers for targeted, non-addictive pain relief. And now GLP-1 pleiotropy for managing chronic disease.
The common thread for me, is the intelligence and the specificity of modern drug design. We are finally moving away from blunt instruments. No more chemo that kills healthy cells, no more opioids that hijack the entire brain. We're designing molecules that hit the exact pathological mechanism and hopefully nothing else.
These are real data-backed answers to some of humanity's toughest challenges. And as you think about all this, here's a final provocative thought for you to consider. Given that semaglutide's protective mechanism is so powerfully anti-inflammatory and anti-fibrotic processes that drive so many other chronic diseases, like fatty liver disease or heart failure, what other conditions, those also driven by chronic inflammation and scarring might be completely redefined by these drugs if we confirm they work outside of diabetes. The story of the so-called weight loss drug is clearly just beginning. Keep learning and stay well informed.